Asthma is a respiratory disease where the airways become inflamed and narrowed, making it difficult to breathe. Patients often experience symptoms like coughing, wheezing, shortness of breath, and chest tightness. In this video, we'll explain what asthma is, why it happens, and how it can be managed. So stay tuned if you want to understand this important condition in a simple and clear way. Definition: it's chronic inflammatory disorder of the airways, characterized by episodic, reversible airway obstruction, leads to wheezing, cough, chest tightness, and shortness of breath. Pathophysiology: first, airway hyperresponsiveness leads to exaggerated response to triggers. Second, key mechanisms: A. Bronchoconstriction, its contraction of smooth muscle around the bronchioles. B. Airway inflammation, its infiltration by mast cells, eosinophils, and T. lymphocytes. C. Mucus hypersecretion, it plugs the airway lumen. 3. Bronchial asthma is two-phase. A. Early phase minutes, mast cell degranulation, and secret histamine and leukotrienes that lead to bronchospasm and mucus secretion. B. Late phase, hours, eosinophils and T helper cells, cytokines, interleukin-1, 5, and 13, sustain inflammation and tissue damage. 4. Chronic remodeling, if uncontrolled, leads to thickened basement membrane, smooth muscle hypertrophy, fibrosis, and less reversible obstruction. Triggers: 1. Allergens, dusts, mites, pollen, and pet danger. 2. Irritants, smoke, pollution, and strong odors. 3. Infections, especially urinary tract infection. 4. Drugs, aspirin, NSAID, and beta blockers. 5. Emotion and stress. 6. Exercise. 7. Cold air. Clinical features: wheezing, cough, often nocturnal, chest tightness, dyspnea, shortness of breath, episodic symptoms, often worse at night or every morning. Diagnosis: 1. History and physical exam. 2. Spirometry. A. Decrease FEV 1/FVC ratio. Obstruction. B. Reversibility. FEV1 improves after bronchodilator. 3. Peak respiratory flow rate, variable and reduced during attacks. 4. Methacholine challenge if diagnosis uncertain. Calcification: intermittent, less than 2 days per week. Normal function between attacks, mild persistent. More than 2 days per week, minor limitation. Moderate persistent. Daily symptoms, some limitation, severe persistent. Continence symptoms, frequent attacks, and marked limitation. Treatment: 1. Relivers, acute attacks. A. Short-acting B2 agonists, e.g. salbutamol, albuterol. B. Anticholinergic ipratropium. C. Systemic corticosteroids in severe attacks. 2. Controllers, long-term prevention. A. Inhaled corticosteroids. B. Long-acting B2 agonists. C. Leukotriene receptor antagonists, montelukast. D. Theophylline, less used. E. Biologics. E.g. anti-Ig amylizumab, anti-I-15 mepolizumab in severe refractory asthma. 3. Non-pharmacological. A. Avoid triggers. B. Patient education, inhaler technique, and action plan. Complications: 1. Status: asthmaticus, severe, prolonged attacks, and life-threatening. 2. Airway remodeling, chronic and less reversible obstruction. 3. Respiratory failure in severe cases. Key points: 1. Asthma equals type 1 hypersensitivity reaction. 2. T helper, 2 cells, IgE, and eosinophils are control to pathogenesis. 3. Reversible airway obstruction is the hallmark. 4. Mainstay treatment: inhaled corticosteroids and bronchodilators. 5. Severe and persistent inflammation can cause irreversible damage. And that brings us to the end of today's video about bronchial asthma. We learned what asthma is, its common symptoms, and the basic ways it can be managed. Remember, asthma is a chronic condition, but with proper care and treatment, patients can live healthy and active lives. If you found this video helpful, don't forget to like, share, and subscribe for more medical topics. Thanks for watching, and see you in the next video.